Welcome back to Sensible 2020. I'm your event host, Seth Adler. It is my honor and pleasure to do this. We've had great sessions to date. We've had great speakers to date. This session and these speakers are no different. It is applying a human rights framework to drug policy. Your moderator is Jake Agliata. Jake?
Thank you, Seth, and hello, everyone. Thank you for joining our virtual plenary today, applying a human rights framework to drug policy. My name is Jake Agliata. I'm an SSDP alumni from Dickinson College, and I have the pleasure of being your moderator today. I'm joined here by three experts in the fields of human rights and drug policy: Heather Haase of the New York NGO Committee on Drugs, Dr. Joanne Csete from Columbia University, and Sanho Tree from the Institute for Policy Studies. As drug policy activists, we often talk about how we want a human rights approach to drug policy. And what we want to dive into today is exactly what we mean when we say that. This is an especially timely discussion to be having right now amidst the COVID-19 pandemic, because in times of global crisis like this, reflecting on human rights principles is especially important because not only does it ensure actions taken by countries are proportional and not excessive, but it allows us an opportunity to examine the existing flaws in our society which exacerbate and contribute to the crisis. We hope you take away from this plenary an understanding that human rights are much more than just an activist buzzword. They are an entire system of principles which can help guide us towards public health and drug policies, which place people and communities first. I want to turn it over to Heather Haase, who will give an overview and discuss the changing landscape of human rights in the international drug control systems.
Great, thanks, Jake. I just wanted to say hello to everybody and thanks for the opportunity to be here. Let me switch over. Okay, can you all see that? Great, so I'm going to sort of set up the human rights framework and with drug policy at the international level. And then we'll take it sort of from the theory down to more practical application of that. But so I'm just going to go sort of through the legal background first. I'm going to assume that a lot of you have already kind of familiar with this because SSDP has been doing a few of these over the years. So I'm just going to touch on some of these concepts. But first, I'll just go over the sort of the legal background. So the international drug control system, as many of you know, is governed by three international treaties: the '61 Single Convention, the 1971 Convention on Psychotropic Substances, and the 1988 Convention on Trafficking. So basically, they say in the drug world that they're supplemented by a series of human rights treaties. Now, there are dozens, maybe hundreds of human rights treaties and agreements. But these are sort of in addition to the UN Charter and the Universal Declaration of Human Rights, these are the 7 core treaties. I'm not going to go through them all, but just know that there's, of course, this human rights treaty body. Now, these two treaty bodies have been basically in silos for years. And the framework, when I talk about the framework, it really has to do with the evolution of human rights at the UN or at the international level, because it really has been an evolution over the past 10, 15 years. Human rights has come a long ways in becoming more prominent in international drug law. So at the UN, the Commission on Narcotic Drugs is the main policy-making body, and the UN Office on Drugs and Crime, many of you know, the UNODC is the main agency that's in charge of implementing the policies on drugs at the UN. And then there's also the INCB, which is more the guardian or the compliance board, but it's not really an agency. And then the WHO has always had a limited treaty-based role in drug policy making. And you've probably seen a lot of the WHO recently with their recommendations for cannabis rescheduling over the past 18 months. Over the past 10 years or so, and especially since the 2016 UNGAS, can you turn off that phone, please? Can you turn it off? So over the past several years, and especially since the 2016 UNGAS, the UN General Assembly Special Session on Drugs, that really opened the door for more agencies to become more involved in drug policy at the UN. And so UNAIDS, which has always had some involvement in drug policy, or at least in the past 10, 15 years, has had a much more prominent role. And UNDP, the UN Development Program, and even the Office of High Commissioner of Human Rights has become increasingly involved. And in the UNGAS process, there was a mandate for these agencies to submit discussion papers. And this led to more discussion papers. And now there's an excellent body of guidance from the UN agencies on drug policy sort of within their mandates. But these documents are generally very helpful and very progressive. And we have a list of those that we can share, that we will share with you. Another thing that's really changed a lot over the past, at least the past 10 years, is the dialogue at the UN and on the international level on human rights. So back in 2008, the Special Rapporteur on the right to the highest attainable standard of health said, he referred to the two areas being in parallel universes. It's imperative that the two systems cease to behave as though they exist in parallel universes. He was referring to watching the delegates go from the Human Rights Council over to the Commission on Narcotic Drugs and do completely different things. A member of the Chinese delegation said in 2008, in response to the adoption of a resolution on human rights, said, "It is ridiculous to require the CND to work in accordance with human rights law." And that was not an uncommon sentiment at the time for member states to say. And then I think the most striking change has been with the INCB, the International Narcotics Control Board, in 2012. And this was a common thing for them to say. They would be often criticized by NGOs for not calling out countries for human rights violations. And they would basically say, well, we don't do that. That's just not in our mandate. So they would give accolades to countries for having stronger enforcement measures, but they would really call them out for, I mean, they would never call them out for human rights violations. So this is actually at one of the informal dialogues at the CND. They hold these in the margins of the CND. And this is the president of the INCB at the time, Hamid Götze, and he was saying, no, we don't. That's outside our mandate. We do not address human rights violations. And someone in the audience, an activist, I think it was Alan Clear from Harm Reduction Coalition, said, "Is there any atrocity so horrific that would make you step outside your mandate?" And the INCB president said basically, no, there isn't. So that is completely different now. And that it's been a very short period of time, really. So now, just in 2016, like there was an entire section of the UNGAS outcome document that was dedicated to human rights. And there are whole days dedicated to thematic debates on human rights at the Commission on Narcotic Drugs. Not that it's not still contentious, but it's much more central to the debates. Another thing that happened was in the Philippines when the extrajudicial killings began under President Duterte, both the INCB and UNODC came out and said that this was a serious violation of human rights and clear violation of the international drug control treaties and an affront to the most basic standards of human dignity. And this would never have happened during this time. That would never have happened under Hamid Götze, who, by the way, is no longer living. But INCB also frequently calls on states to consider the abolition of the death penalty for drug-related offenses. And this is a regular occurrence now that would have never happened 10 years ago. So things have really changed, and it's not just rhetoric, it's really become part of the landscape. Not that there's not a lot of work to do or a lot to go, but it's definitely changed. One thing that the UNGAS also led to was the UN Common Position on Drug Policy. So the engagement of these agencies really led to this new development. So the Common Position was adopted by the Chief Executive Board for Coordination. That's all the agency heads that come together and address different issues, and it's chaired by the UN Secretary General. So basically when Secretary General Antonio Guterres took office, he took a special interest in drug policy. He brought the UN agency heads together to come up with this common position. It's to enhance system-wide coordination. It supports governments in developing and pursuing evidence-based and rights-based, human-centered, and integrated response for addressing the world drug problem. And it also resulted in a special UN system coordination task team. So this is a pretty huge development. And also the task team, the UN system coordination task team, is tasked with coming out with briefings. And their first briefing was what we've learned in the past 10 years. So between the common position and that document, I mean, both of those documents are extremely progressive. They call for support for, increased financial support for harm reduction. They call for decriminalization for possession, and just among an array of very positive measures. And this is a document that basically it's not a policy document for the C&D member states to follow, but it is a guiding document that the UN can now implement at country level. So to sort of go back, quickly review kind of the framework, it starts with the drug control treaties, which are supplemented by human rights treaties. That's not far enough in my opinion, but it's the drug control treaties, which are basically very enforcement based. And then the soft law under the drug control treaties, which is the resolutions and the declarations, all of the non-binding instruments that have been adopted over the past decades, and they have become progressively more pro harm reduction, pro public health over the years. And then the common position, which is the agency guidance document, and then the agency publications. And like I said, we'll give you a list of the main ones, but one of the most positive and progressive documents over the past few years has been the International Guidelines on Human Rights and Drug Policy. So you can see though that this goes from drug control treaties, the most binding, to agency publications, the least binding. And it also goes from drug control treaties are the most enforcement based, the most punitive, and down to progressively more pro human rights based and pro public health to agency publications. So the least binding documents are the most progressive, in other words. So I've just written a paper, and it's a proposal for a new supplemental treaty based on principles of public health and human rights. So this treaty would be a convention that would be entered into by a smaller group of member states, a group of friendly member states, and they can do that as long as it doesn't derogate from the current provisions of the treaties. And so basically this treaty would fill the gaps in the current enforcement-based treaties with health and human rights provisions. It would then elevate many of the concepts that are already agreed in the soft law to the binding international law, and then would add some more. Would really aim to be a very progressive agreement. It would have funding implications, so it would draw funds to more public health and human rights based provisions. And this could also lead to a uniform model law, like an implementing law applying the human rights concepts to drugs at the national level as well. So that's my goal, but I hope I've given you an understanding of the system overall and how that's changed over the past 10 years. So now that we can move on to what that looks like at a practical level.
Great. Thank you very much, Heather, for that very useful background and all that great updates about the role of human rights in the international drug control framework. Very useful. And also just to state to all of our watchers right now, we'll be making these slides available for you after the conference airs, so you'll be able to see all this. Now I want to turn over to Dr. Joanne Csete from Columbia University, who's going to be talking a little bit more specifically about the right to health and public health as it pertains to rights-based drug policy.
Thank you so much. I hope you can see the slides. I want to, first of all, to thank all of you who are active with SSDP. Your mobilization of a student voice is so important. For those of us sitting in universities, we really appreciate it, but more broadly as well. The evolution in the dialogue that Heather just talked about has led to a place where lots of countries tend in international meetings to stand up and say that they take public health approaches to drug control even countries that have relatively harsh drug laws. What does that really mean? It's a good question. We know that some of these countries do have commitments to a right to health in their national law, sometimes in their highest national law, their constitutions. And what that should mean, and the commitment that's embodied in that commitment to a right to health, is an aspiration to health that is universally accessible and affordable, that's respectful and not stigmatizing or discriminatory, whatever level of health services is offered, that's scientifically sound, that's delivered by qualified people, that's not cruel, inhuman, or degrading. That's language from the human rights standards. And also that recognizes that we never really get to health alone if we don't recognize and address the underlying social and economic determinants of health outcomes. I don't have to explain to you that all of those are particularly pertinent to the matter of services for people who use drugs. I wanted to show this slide not because HIV is the best indicator of everything, but because I think that the effective elimination of HIV linked to drug injection as a public health problem in much of the European Union is really a function of some parts of the right to health that have been achieved in some of these countries and that we still aspire to in the United States, namely a commitment to really a broad range of harm reduction measures and proper investment in them so that they can meet the demand. Maybe the most important of all is effective decriminalization, or at least depenalization, of minor drug offenses, including minor sales as well as minor possession, and generally better health systems, quasi-national or nationalized health systems, and better access to social services. All of those are things that we need to keep working on. You all know, for instance, that there are in many parts of Western Europe supervised injection facilities, supervised consumption facilities, supervised consumption spaces, and they have many names, that we haven't been able to get far on in this country, even though there are cities, as you well know, that have plans for them. And some of you will know the Philadelphia story better than I do, but we really are tripping over ourselves at a time when we have an overdose mortality crisis to be able to even put this cost-effective and well-proven public health measure in place. Same with syringe exchange. We could talk about this for a long time. We know that some of the places now that have the greatest need for people to get help in getting injection and inhalation equipment are really without those services completely. And these are for reasons that we know are political. They have nothing to do with science. This is really, in my mind, cruel, inhuman, and degrading. And not just nationally, but globally, the underinvestment in harm reduction services that we know are proven, that we know are cost effective, that we know have worked in many ways to help people, not just with respect to HIV, but with respect to a lot of other health outcomes. The underinvestment is really a scandal. As you can see here, globally, we estimate that just about 7% of what's needed is actually invested. In the US, it would probably be on that order too. Cruel, inhuman, and degrading is a good description, I think, for the way that a lot of our most essential health services are delivered for people who use drugs and people who have drug use disorders, who I know are a small subset. But if we look at methadone, for instance, the way that people are required to go to stigmatizing standalone places, they're required to be observed in their consumption of the medicine and so on, at a time, especially when we're all living under stay-at-home orders, we have jurisdictions that are not even struggling to think about take-home doses for people who are really trapped in their homes, if they have homes. So these are things that we really need to be thinking about in a different kind of way if we want to aspire to a rights-based approach. Same is true for hepatitis C treatment. For instance, we have this great new generation of medicines, but we have states in the US that still make people jump through all kinds of hoops that, again, are not scientifically or medically dictated in any way. A history of alcohol use, a history of drug use, all these things that really shouldn't matter for people to be able to get access to the directly acting antivirals. We know that there remain many, many barriers to getting access to naloxone. to the scale that's needed, including the failure of governments to stand up to the manufacturers that are setting the prices out of range of many users, including lack of insurance coverage, including pharmacists who don't want to sell it, including EMTs and police who don't want to use it, and so on. We have a long way to go, especially for people now. If we think now that people are being released from prisons, they are in some parts of the US, they're often being released without any kind of help to be sure that the high risk of overdose that they will face in many cases can be mitigated by measures like naloxone access. But we need to be thinking in the current situation beyond sort of our traditional rights-based harm reduction measures that have to do with infectious disease. We really need to be thinking about the fact that we must recognize that some people, for whatever reason, are getting their drugs on the street, and we need to think about the safety of those drugs, because we know that fentanyl is taking a big toll in lives and in sickness as well. We have instruments now to be able to detect fentanyl, for instance, in street drugs. Not that, let me just skip that. This research from Johns Hopkins University showed that these strips are not perfect, but they're pretty sensitive and pretty specific in their detection of fentanyl in the drug supply. Why don't we use them more broadly? They're relatively cheap. It's a good question. We also know that in parts of Western Europe and also in Canada, a safe supply measure for people who haven't been able to benefit optimally from the traditional agonist therapies, methadone, buprenorphine, and also now naltrexone, are allowed to be in programs where they are provided with medical grade heroin. These are exactly the people who would be on the street getting adulterated drugs otherwise. These are important programs. They really should be expanded beyond the small populations that they serve in many countries. And we can't even really start this discussion in the US. It's politically extremely difficult, and yet these programs have been shown over and over again to be of importance in public health and in the preservation of rights. I wanted also to mention that our friends in Canada are really thinking outside the box, or in other kinds of boxes when we talk about safe supply. This experiment that's going on in Vancouver now of a dispensing machine, ATM kind of machine for hydromorphone. While there is in Vancouver a prescription heroin program, it's very rigidly structured, and the people in the local network of people who use drugs have called for this experiment that allows people a little bit more flexibility. This is a machine that's biometrically controlled with handprints. These are people who all have prescriptions. They've all seen doctors to be able to use this machine, but they can use it much more flexibly, and that helps in their lives to get them into safe supply programs that they wouldn't perhaps be able to get into otherwise. Can we learn from this? We certainly should learn from this. This is a great rights-based experiment. There's lots of discussion around the world as well about the model that has been used so much for marijuana, for cannabis, of social clubs, that is sort of creating a closed network, a closed market in which one can control, the club members, as it were, can control the supply that's before them so that they can be sure that it's not adulterated. Is this the kind of thing, and this question is being actively looked at again in Canada and parts of Europe, is this the kind of thing that can be also a safe supply measure for opioids? I do want to say as well that I think it's an important part of a broad notion of harm reduction to think about how it is that we talk about drugs to young people. We've been so stuck in this country spending millions and millions of dollars, wasting millions and millions of dollars on programs that are about preventing all drug use, just say no, abstinence-based kinds of programs. And there are other countries, and now a little bit of experimentation here in the US, that I think also is very rights-based, educationally speaking, that look rather at preventing the most problematic forms of drug use, helping young people to know not just how to be clean at all costs, but how to be safe. And I really applaud the Drug Policy Alliance's experiment now with its Safety First curriculum, which is a very different approach to talking to kids about drugs. I think that this is the way that we create a generation that may even advocate for better rights-based drug policies. I don't have to say much about the fact that the US is such a heinous outlier when it comes to incarceration. This is not all incarceration related to drugs, but drugs and minor drug offenses certainly contribute to it importantly. When the US stands up to talk about its own public health approaches to drugs, it always talks internationally about the drug courts. I'm sure you all know and have had contact with them. I hope that you bring a critical eye to them. But one thing I want to say, and there's a whole body of research, and that could be a talk in itself about whether the drug courts are really scientifically sound, are really human rights based, are really public health based. But one thing I will just underline is that in the middle of an opioid overdose problem, we have maybe the majority, certainly a significant percentage of these drug courts that won't allow methadone or buprenorphine as court-supervised treatment options, just really because in some cases of the prejudice of people who run the courts. I hope this is something that you'll have on your advocacy agenda. So just to end, I wanted to say that, you know, when we think about measuring our success in drug control, we've really been stuck on the wrong metrics if we want to talk about rights-based and health-based drug control policies. We have to get off this business of measuring our success by arrests and incarcerations and even tons interdicted or seized. We rather need to be thinking about whether people are getting access to the social and health care that they need, and whether we're making real steps toward alternatives to criminal prosecution and infractions. Thanks very much.
Thank you very much, Dr. Csete. And I think that conversation about safe supply is so critically important. I'm glad you brought it up because it's definitely one of the things that we need to be discussing more as a global movement moving forward in a very upfront and honest way. So thank you for bringing that and everything else that you just discussed. So I want to turn it over to our final speaker on the plenary right now, Sanho Tree, who is going to talk a little bit more about global hotspots on this topic that are occurring right now and dive into a little bit of relevant conversation about how the discussion around human rights and drug policy is playing out right now as we are under a global lockdown due to the COVID pandemic. So Sanho, take it away.
Thanks, Jake. It's an honor to follow Heather and Joanne. My presentation is going to be slightly different. I'm going to show a few images, but no PowerPoint. But what I want to do is talk about, take you on a globetrotting tour around the world to see the connections between sometimes drug policy. It may not always be obvious, but how the drug war and those nations that have plagued us in terms of you know, the really brutal states, how they are dealing with the lockdown and how that's impacting people. Because drug policy, and I've been doing this for 22 years now, is one of the most interdisciplinary problems I've ever studied. And that's what makes it hard to solve. And it makes it hard to talk about the totality of this problem. But if we only stick to our own silos, we end up talking to ourselves. So I want to find ways, lenses for ways to talk to your colleagues and friends about these connections. So I do a lot of work on the axis of authoritarians and the war on drugs. So there are these, it's not a formal alliance by any means, but there are these right-wing global governments that have waged vicious drug wars. And how they're reacting to COVID, I think it teaches us a lot. So the most obvious example, I think, would be the Philippines, where the drug war is the most deadly and brutal right now. President Duterte, since he took power in 2016, has killed, by many estimates, up to 30,000 people. No one really knows the ultimate death toll so far. That's been on pause for a little bit because of the lockdown, but he's using many of the same tactics to keep people who are often very, very poor, don't have more than days worth of food stockpiled in their shacks, and preventing them from going out and getting food. And in fact, he's issued shoot-to-kill orders for people who resist the curfew and cause trouble. And one person has already been killed as a result of that. But he's been able to get away with not only the drug war, but also these brutal lockdown tactics by employing these strongman tactics that made him very politically popular, and he still is very popular within the Philippines. But he gives simple answers to very complex solutions. This is a common theme you'll see, whether it's talking about Donald Trump or President Erdogan in Turkey, or President Orban in Hungary, or President Bolsonaro in Brazil. These are really far right-wing governments that take a cornucopia of social ills, project it onto minority groups and say, aha, that's why we have all these problems in our society. Just unleash holy hell on these people, get rid of them, kill them if you want, and that's how we get to a better world. So President Duterte, I think, is the most obvious example of that. But what he's been doing reminds me very much of what the Tsarist Russian secret police did in the 19th century. They waged a pogrom, right? A pogrom is where you take a cornucopia of social ills under Tsarist Russia, and you project it onto a minority group. In this case, it was Jews in the 19th century. And you say, aha, they're the reason we have all these problems. Just unleash holy hell on this group. And that's what they did. And President Duterte has flipped that formula and adapted it to the drug war. Now, the drug war is awful and it's bad and all this, but what's really important about this is that once you condition your police forces, once you take your security forces and get them to be able to identify, to track, and then to murder extrajudicially people that you don't like, once you train them to do that, then you've got a really powerful and dangerous tool, right? It's getting your cops to kill the first person is the hard part. The next 100 murders are really easy after that. And so it's very important for us then to look at the drug war and how it's going to be used, because they can take that apparatus and then turn it on a dime to go after other targets, curfew violators under coronavirus, or they can go after labor organizers next year, feminists, indigenous organizers, sexual minorities. It's very easy to use a kind of scapegoating tactic and that apparatus to go after people. And so I think it's an exterminationist policy. It's an eliminationist policy, and one that is morbidly being used, talked about by various political actors. There's some very cynical stuff going on. So President Bolsonaro in Brazil, who came to power last year, they call him the Trump of the tropics. Far, far, far right president. He was a military officer in the junta in the 80s, under the dictatorship, and he's talked openly about returning to a dictatorship. He is a huge coronavirus denier. He says it's just a little flu, and he absolutely refuses to go along with these lockdown policies. And he's on the brink of firing his health minister right now. And this portends very badly for the rest of the world, because if we are able to manage to suppress this problem in the Northern Hemisphere, as we go into summer, it'll be their winter down there, and Brazil is a huge reservoir of this virus, and it could come rocketing back to us in the next season. So these things have global implications. And so we need to pay attention to this axis of authoritarians, not just how they employ the drug war, but how they use social control. And President Bolsonaro also, when he ran for office, spoke openly and admiringly of President Duterte in the Philippines, saying, I'm going to do even more than he did in terms of the drug war. So this is the kind of mentality we're dealing with right now. In Colombia, another country that has done a lot of work in Colombia over the years, and they're thinking of returning to this disastrous policy of aerial fumigation, of spraying to try to destroy these crops. But beyond that, there's also the problem of human rights defenders and people who work for social justice under the drug war have been targeted, are especially being targeted in recent years, especially after the recent peace deal, because there's a grab for land, for power, for resources in Colombia. And a lot of these people are now being threatened and assassinated. Some of them have worked on drug policy issues in the past. They also work on indigenous rights issues and peasants' rights issues. And what's happening with the lockdown is that once these people are in quarantine, they can't go out. And so now the death squads know where to find them and hunt them down. I think that's an incredibly sobering thing to keep in mind, quite apart from the drug war. In Guatemala, we just found out 2 days ago that the U.S. has been deporting people, detainees, for immigration violations who are positive, who are actively ill, and sending them back to Guatemala, which I think is an absolutely sick and disgusting and an insane thing to do. We're sending vectors back to these regions to spread this disease. And I think, quite frankly, it fits very nicely with Stephen Miller's agenda, which has always been to conflate immigration with crime, disease, rape, all these the social ills that, go back to the Third Reich in terms of that kind of dehumanization and scapegoating. And now he's able to then take these people, send them back, create more disease, and that forces that it gives them a feedback loop and say, that's another reason we have to keep these enforcement policies in place, is because they carry disease. Well, we're actively contributing to that in a horrific way. In other places, there are more, I guess, in a perverse way, optimistic things going on. In places like El Salvador, Brazil, Cape Town, there are gangs that have been fighting and feuding for many, many, many years, killing each other. And they're now actually declaring truces amongst themselves and trying to provide basic social services and enforce the lockdown where their own governments won't do it. So they're the ones kind of keeping order and making sure people get fed. This is a double-edged sword because these are criminal groups. But on the other hand, it's a great way of illustrating the struggle for legitimacy. The state should not have to fight this hard to establish legitimacy within their own borders. It really highlights what they haven't been doing. And people who've been involved in the drug war have known that for a long time. These are marginalized populations they've never really taken care of. And it's no mystery why these gangs are able to get traction today, because they're actually fulfilling a role that the state won't or hasn't been able to.
And then, 1 minute warning.
Yeah. And then finally, I just want to show you a couple of images to think about. These are some photos from, let me see. From the Philippines. Wait, I'm sorry. This is when I talk about disease. Here's one. Is that sharing? This is a major prison in the Philippines, right? This is taken back in 2016. It's been overcrowded, but especially so after President Duterte declared his drug war. And so those who were able to turn themselves in got locked up. And I've been saying for years, we need to pay attention to disease, not just now under coronavirus, but in situations like this, where you have these right-wing governments that lock people up in horrendous conditions. This is a breeding ground for disease. And tuberculosis is bad enough, but now we have strains of multi-drug resistant tuberculosis, which scare me as much as this coronavirus does, because we literally have no cure for them. And once that comes out, it could plague the rest of the world. We need to take these kinds of situations very, very seriously. And then finally, in closing, what we're living through today, keep in mind, this is not unlike what indigenous peoples confronted 500 years ago in this hemisphere, that a disease where people have no natural immunity is taken over and caused unprecedented damage. By some estimates, up to 90% of the indigenous peoples in this hemisphere were wiped out before they even were able to lay eyes on a white person. The disease travels much faster than the colonizers. So as we think about things like Colombia and how do you deal with drug cultivation and helping the human rights of drug producers, we need to also keep in mind the rights of indigenous peoples and how we're affecting their lands and their lives and their life ways. So thank you very much.
Wonderful, Sanho. Thank you so much for that very powerful talk, especially that last point about relating back to the indigenous population. I think just a really great example overall of how bad it can be and how bad it is in a lot of different places with governments that toss aside human rights when you're talking about drug policy. And just to finally bring things to a conclusion and on an optimistic note, so just today, the Office of the High Commissioner on Human Rights put out a letter on guidelines to states on recommendations for how to keep people who are using drugs safe during the COVID-19 pandemic. It is certainly not a comprehensive statement, and there are some things that could be included, but a great example of a positive action that a UN agency has taken to state very bluntly what are the specific human rights actions that states need to take to fulfill their obligations under the right to health, under the right to arbitrary detention, all those kind of things. So we'll send a link along to that along with the slides and everything else that we discussed today, the photos. I want to thank everyone again for participating. I want to thank everyone again for watching, and hope you enjoy the rest of the virtual conference.